OIA and our chairman, Shri Sanjay Bhattacharya, JSOIA 1 and CEO ICM, Shri Yogeshwar Sangwan, all our esteemed panelists who are being moderated by Dr. Nishi Madan, and officers from MEA, friends, colleagues, people who have joined from international organizations, various other government bodies, think tanks, research institutes. Everyone, welcome to this panel discussion. I'll now request Secretary CPV and OIA to make his welcome remarks. Thank you.
Thank you, Surabhi. Can you all hear me?
Yes, sir, we can.
Thank you, Surabhi. This is the second webinar being organized by ICM in the coronavirus days. We had a wonderful session last time on the returnees from the Gulf, and one of the themes that came up over there was which are the sectors which will see good momentum that we can take into the post-corona period. And quite obviously, the healthcare sector is one of those. And so it's very appropriate that we are having this particular session at this time. I would really wish to thank you, Surabhi, for getting such an eminent group of panelists across. The contributions of such discussions are extremely important as we frame our policies and look towards the post-corona period, because the objective that we would wish to have is to take care of the best practices so that we can be ahead of the curve, to ensure that we can tap and figure out which are the potential areas where our people can do better and progress in those areas. So I'm very, very happy about this particular session. Well, on the healthcare sector, if I may just say a few introductory words, this is something that India has always excelled in, and Indian healthcare workers across the world have always had a very strong reputation. In fact, very soon after independence, we had seen the surge of Indian healthcare workers moving overseas. A lot of them would move to the US and UK in the early days. And then from later on, we saw that there were new growth areas. So in the past, we would see UK, US, Australia, Canada, where there would be a lot of people from the healthcare sector. And of late, we've seen that the Gulf has emerged as another area. Traditionally, we've had a very strong presence in a large number of countries in Southeast Asia and in Africa as well. Now, there are two sets of healthcare workers that we see going out. I'm told that in terms of nurses, we have a very strong capacity with over 1,500 institutions that are training nurses, and something between 20 and 50% of those trained are looking for migration overseas. And some of them have acquired a very, very high reputation in the countries that they go to. A trend that had begun even earlier was the one of doctors, physicians, surgeons who would go out. If you look at the NHS in the UK, a very large number of them are of Indian origin. Similarly, if you look at the US, you will find that there are a very large number of Indians there, as well as in many of the other countries. I'm told that NCI did a study which seemed to project that something like 8% of those who had trained in India and were registered with them had actually ended up in assignments overseas. So we have seen that we have a large pool outside. They are well appreciated. Very recently, for instance, November last year, the UK announced a fast-track system for medical professionals, and this would be a good opportunity for many of our Indian professionals to move towards those areas. Within the country as well, we've seen there has been a greater coordination of efforts. NORCA has worked very hard, particularly on the nurses, as has Telangana Overseas. And I understand Telangana Overseas has concluded an agreement with the NHS of to become a health education provider and set up a base in Telangana. And of course, there are other agencies, including the Overseas Development and Employment Promotion Consultant, who also work very actively in some of these areas. Now, I see this not merely as a group of people who are going overseas, and who are going overseas purely for economic reasons. But I think what this also provides us with is an opportunity for sharing or experiencing the practices that are in place in many of these other countries, sometimes bringing them back. We've seen a tendency in which many of the healthcare professionals who've been working overseas have actually come back to the country and have established a presence over here. And then this could also be one in which we could extend the cooperation to areas of pharma industry, the R&D. We've seen, for instance, that we have a very large vaccine production capability within the country. The R&D is often an input that comes from laboratories across the world. So when we look at the healthcare sector, we would like to expand this realm and see how we can have a coherent approach that is towards the entire infrastructure as well as the R&D facilities. I wanted to mention a few things about the current coronavirus pandemic and some of the things that have happened in the course of this with respect to the external sector. As you all probably know, India had sent its rapid response medical teams to Kuwait and also to Mauritius. We have currently an Indian naval ship with a medical facility on board, which is traveling in the Indian Ocean to cover Maldives, Mauritius, Seychelles, and Comoros. So we are trying to reach out to a number of countries with our healthcare abilities and potential to be a first responder in such disaster situations, in such crisis situations, and to bring about a level of cooperation that you would wish develops following this particular situation. The other thing that we have done is that, as you probably know, in the Gulf there are a very large number of Indians who are employed in the healthcare sector. A very large number of them were actually on vacation or, waiting, taking on their tenure, and we have been able to facilitate the movement of such people to Saudi Arabia, Bahrain, and the United Arab Emirates. Over 1,200 such healthcare professionals have been able to go across to help with the facility. As you know, Indian healthcare has a very strong presence in the Gulf. In fact, recently when the Emirati Prime Minister Mohammad Rashid Al Maktoum declared this program of the Golden Residency, which was given to a very small group of people. A large number of them were Indian doctors over there. The other way in which India has reached out to the world during this pandemic has been in terms of supply of medicines. As you know, hydroxychloroquine and paracetamol were seen as some of the initial responses, and India was very quick to provide supplies of these as well as various other medicines. A package which included several antibiotics and others, antiviral medicines, was prepared. We've reached out to 32 countries in Africa, and we are reaching out to 8 more. The consignments are about to reach there. and of course to several countries in our neighborhood and in the extended region as well. So before I conclude, I wish to see that these discussions that you have today will give us inputs, which we would then share with our partners in the rest of the government, in the Ministry of Health and otherwise, as well as with the other stakeholders, so that we can evolve a policy that is responsive to the external requirements of the healthcare sector that India is engaged in. Secondly, that it beefs up the healthcare infrastructure in our country in all its parameters. And finally, that we can carry on this policy of being Atmanirbhar in the healthcare sector. And as the Prime Minister had defined, Atmanirbhar is not a closed wall. It's a very interactive process in which we would be engaging with the rest of the world. I once again wish to thank all of you for joining this panel, and we look forward to your contributions. Over to you, Surabhi.
I would now request Dr. Nishimadan to start the proceedings, and let's begin the panel discussion.
Good afternoon, everyone. It's our privilege to be invited today to chair this session with such eminent people. I'd like to begin the day's proceedings by congratulating Dr. Harshvardhan on his appointment as the Chief Executive on the board of the World Health Organization. He's going to be the chairman. It is a great, great thing for us. Many congratulations to the Ministry of Health as well. So we welcome the participants to this discussion, which I'm sure will be a very interesting one, on mapping India's need versus foreign demand, a case of health sector. In today's increasingly global world, we are interconnected in many ways and need to look at our health and participation in world healthcare, which we are already doing, as the Secretary has just told us. It becomes particularly relevant in the scenario of the current pandemic of the coronavirus giving rise to COVID. The panelists are in their particular field. I'm sure that the participants include Dr. Meera Singh, Thomas Lapita, Dr. P. Srinivasa Rao, and I'm sure some participants from the Indian Council of Medical Research are always here. So I would request our prestigious panelists to speak for 10 minutes. I will also remind them very gently of their time in about when they're 8 minutes into their time. Several issues as outlined in the concept note will be covered by the panelists, which I'm sure to go ahead. I first invite Dr. Meera Singh, Director General Special Envoy to the International Organization of Migration in India, to begin the proceedings.
Yeah. Thank you very much, and good afternoon, everybody, and especially my greetings to the Secretary, to the ICM team, and to the JS and to our moderator for the day. I think as somebody who's working in the international migration for over 30 years, I think I need to say at the outset that national healthcare systems worldwide have come under acute pressure with the COVID-19 pandemic. And never before has one seen the spread of any disease so fast and so far in an interconnected, globalized world. And never before has a movement of people been curtailed so drastically. I do not remember that. And never before have we seen the existing inequalities. You could look at inequalities within countries, within nations, but you see inequalities all along globally. So what we see is that mobility has become a defining feature of the COVID-19 pandemic. It is going to be a game changer for international migration. So addressing some of the questions that we were I'd like to highlight 3 key points. The first point is that India is today, as per the World Migration Report 2020, the largest sending country. It is number 1, and followed by Mexico, Russia, and China. India is also the largest source country for highly qualified professionals. Of course, we also have medium and low-skilled workers going out, but it has gained a lot of prominence, as the Secretary said, for highly skilled professionals. And also what is important is that it is the world's largest supplier of medical doctors and nurses. And when you look at the training institutions, what we have gained and acquired over the years, it's interesting to see that the registered medical colleges, when you look at from 86 in 1965 to 539 in 2019, with an annual intake of more than 67,200 students for the Bachelor of Medicine and Bachelors of Surgery. The story is quite the same when you look at the nurses. And as you rightly pointed out, the numbers of institutions offering nursing training has increased from 349 in 2005 to 1,831 in 2016. And despite such a large supply of trained workers, we do face imbalances within the country between the rural and the urban distribution of our medical health workers. So we see that in the urban sector, we have 78% of physicians who are concentrated in the urban areas, and only 27% of the qualified nurses are also found in the urban areas. And it's very interesting to note that 80% of our medical doctors are in the private sector, and whilst 50% of nurses opt for the public sector because it provides them the job security. And for the nursing in particular, I need to say that when you look at, there are a lot of disparities within states. For example, Bihar has 0.4% nurses and midwives for 10,000 population, whilst Kerala has 18.5. So we can continue with these numbers, but that's not the key point. What I'd like to highlight is that in a nutshell, despite the abundance of supply, India is unable to meet its demand internally and does have a critical shortfall of healthcare workers. You look at 3.3 qualified doctors and 3.1 nurses and midwives per 10,000 population, which is much below the World Health Organization benchmark of 22.8 doctors, etc. And of course, the push factors here are the lack of the low salaries, the lack of optimal working conditions, the lack of opportunities for professional development, as well as the bureaucratic delays, etc. And these make the health workers tend to look overseas. And on the other side, we have a high number of pull factors that are also attracting and trying to get our highly qualified professionals. So when you look at the OECD data, you see that around 69,000 Indian trained physicians worked in the United States, UK, Canada, and Australia. And this is equivalent to 6.6% of the number of doctors which are registered with the Indian Medical Council. Nearly 56,000 Indian trained nurses work in 4 countries, equivalent to about 3% of the registered nurses in India. Now in the US, when you look at the figures, 21% of our foreign trained doctors, this is the number for 2016, and which came from India, 21%, I repeat, and the rest are coming from Pakistan and from the Philippines, which are having a share of 6 and 5% respectively. In the UK, 32% of foreign trained doctors in 2017 are from India, followed by Pakistan, which is 11%. We also have doctors from African countries like Nigeria, Egypt, and South Africa. And when you look at the UK also, countries like Ireland, UK, Germany, Italy, Romania, Poland, you see smaller numbers, but you do find Indian doctors and nurses over there. And of course, not to forget the GCC countries where Saudi Arabia data is available, and you see that 57% of our nurses are migrating to the Gulf. So let's look at it, what's happening on the other side. So when you look at the global demand, it says that there's a demand for 80 million health workers globally, but only 65 million workers will be in the supply, which means that there will be a shortfall of 15 million health workers. Now, I must say, every data that I present to you today has to be taken with a pinch of salt, because you can look at different reports and you will find different projections. But there are several of these reports, and of course it is up to us to get the essence of what I'm trying to say here. Let's look at the EU. According to the latest statement by the EU Commissioner for Health, the EU will have a shortage of 1 million health professionals by 2020, and this will likely reach 2 million if other employees in the healthcare sector are also accounted for. And the forecasts are...
May I interrupt and tell you your time is running out, so please.
I'm finished 8 minutes. Okay. My next point is related to the medical students who are going out of the country. Not the number of aspirants and the mismatch between the numbers who want to apply for medical school and the available seats tends to send and push a lot of our students outside India. So you have countries like China, Russia, Ukraine, Kazakhstan, Nepal have a high number of students. Similarly, countries like Romania, Poland, Ireland are attracting a lot of our Indian students. They are providing curriculums, they are providing facilities, and the ease of admission is there, and the cost of education is much lower than what a student would pay studying in a private sector university in India. But what is interesting is there are two elements here. And one is that many of the Indian students who return have to take the foreign medical examination, the graduate examination, which was established in 1975, and a large percentage, only 25% of students do not qualify. So in a nutshell, I'll have to stop, I know, basically we need to bring in mechanisms to make sure that our potential health workers, wherever they are, whether in the non-resident talent pool or returning students or returnees coming from the Gulf countries, we have mechanisms in place to attract them and to retain them. And we also need a much more comprehensive data on the outflow and the inflow of our health workers, which right now is absolutely fragmented. And of course, twinning arrangements with universities, exchange of students, exchange programs, aligning of curriculums is extremely important. I will stop here, and I hope we will have a chance to bring in other elements. Thank you very much.
Thank you, Dr. Meera Sethi. I'll request now, before we go into the question and answer session later, Professor Rupa Chanda. Hello, Dr. Chanda. We haven't met before. I'm Dr. Nishi Madan. You are Chair, Economics and Social Sciences, the Indian Institute of Management in Bengaluru. Please take your position.
Can we can't hear you, ma'am.
Perhaps the microphone needs to be checked.
Can you hear me now?
Yes, we can hear you.
And can you see the screen? Sorry.
Yes, we can do that. Please go ahead.
Yeah. Okay, so thank you very much to Surabhi as well as ICM for giving me this opportunity. So this is the outline of my presentation. I provide a brief sort of global context for health workers, how India is placed within that context, what are the human resource challenges, and I'd like to concentrate on what the approaches are to trying to address the global demand without undermining domestic capacity. So if we look at the global situation, we know that there is a big shortage of healthcare workers, and a lot of countries really do not have the requisite healthcare workforce to deliver the services needed to achieve universal health coverage. This demand-supply gap is increasing, and Dr. Sethi has already outlined some of the estimates. Of course, there's quite a range, but broadly, because of the rise in demand, the demographic challenges, and so on, there'll be a huge shortfall estimated for healthcare workers. This demand-supply gap is actually concentrated more in the lower-income countries and lower-middle-income countries. But the EU, for instance, as estimated, has about a shortage of 1.8 million health workers projected by 2025, and there are various other countries which also similarly show shortages. And the other thing to note is that the countries which actually have a high burden of disease are also the ones which do not have much of a healthcare workforce, and they're also the providers of healthcare workforce to other countries, the richer countries. This is from the WHO, which is kind of showing the universal health coverage on the y-axis and the health workforce density on the x-axis, and it's showing that there are some 43 countries critically placed which are performing badly on both of these indicators. So this is basically to show that some of these countries actually are the ones which are the source countries for migrant workers around the world. So there is a big maldistribution that is there, and this is really going to affect global health security. Now, obviously, this demand-supply gap that is there has given rise to a lot of migration, and Meera Sethi has outlined some of these numbers, so I won't go into that. But nurses, for instance, 1 in 8 nurses are practicing in a different country. There's been a huge rise in the OECD countries in terms of foreign migrant health workers. But an important thing to note, we often talk about north, as if it is from south to north, but there's a huge amount of south-south movement of healthcare workers and intra-regional movement of healthcare workers. And there's a lot of transitional movement. So it's a very complex sort of dynamic that is going on in the healthcare sector. This is just the OECD numbers in terms of share of foreign trained doctors. And as a result, of course, we do see a variety of schemes, immigration schemes, to try and attract healthcare workers. The NHS one was mentioned. We are also seeing a rise in private recruitment agencies and the growth in terms of the scale of recruitment that is going on, as well as the point mentioned about more aspirants for international medical education so that they can get jobs overseas. There's also some evidence on unethical treatment of migrant healthcare workers and discrimination between the domestic and the foreign health workforce. What are the implications of COVID? Obviously, what we are seeing is that there is a huge inadequacy in terms of the supply of qualified health professionals as well as of health systems preparedness. And we're seeing that frontline workers have been forced to work longer hours. The rising infections, deaths, and so on further aggravate shortages. One could expect that this is actually going to make the pull factors even stronger in future, because already some countries are looking at easing their medical recruitment process. They are advertising in the poorer countries to attract healthcare workers. The US is trying to attract doctors and nurses with the promise of green cards. So these kinds of changes that may happen post-COVID will aggravate the health workforce shortages. So yes, there'll be new opportunities, but the divide between the countries which are already facing shortages and those which have the money and have the working conditions and so on, that divide is probably that imbalance is going to grow. Now, how is India placed? As has already been pointed, we are a big supplier of doctors as well as nurses. A large number of these are present in the OECD countries, especially the English-speaking ones, but also a large number in the Middle Eastern region. Of course, there is an imbalance within the country in terms of which source states they're coming from. Kerala, of course, dominating. These are just some numbers in terms of the top 5 destination countries among the OECD and the immigration source states with Kerala topping. Now the paradox is, as also was mentioned, that we ourselves have a shortage, though we are exporting a large number of healthcare professionals, and we are projected to face the biggest shortage of nurses in the world after Bangladesh. And if you look at the WHO guidelines, we don't meet those norms, we are well below those. So there is a paradoxical situation here of exporting while not being able to meet the quality and the requirements of the domestic population. And the shortage is also uneven, as was pointed out, across the state. It's also uneven in terms of urban-rural. There are quality issues as well, because a large proportion actually do not have proper qualifications. There are studies which show that a large number of them are unqualified. And there is a lot of, there are anomalies in terms of the medical education system with profiteering, issues of quality, uneven distribution, etc. So it is not like we can export without addressing many of these domestic problems that plague our medical education system as well as the institutions. And out-migration actually compounds this problem to some extent unless we address it in a way that is mutually beneficial, both addressing the export possibilities from this as well as bringing in, as the Secretary mentioned, bringing in these migrants, bringing in the qualifications, the additional quality, upgrading of standards, etc. Now, what is driving, as was mentioned, there are a lot of pull and push factors. There's lack of investment in health, not good working conditions, poor human resource management practices, etc. But to some extent also proactive policies by some corporate health groups which are involved in training. There are international partnerships which are facilitating some of these worker exchanges. What has been the government's approach? Rather ad hoc, I would say. I mean, there's not really a holistic sort of long-term strategy. There are steps periodically to curb or regulate the movement, to prevent exploitation, to try and regulate the recruitment agencies. At the same time, there are also steps to promote. There are bilateral agreements with certain countries. There are arrangements to try and tie up training institutions so that there is also a sort of development benefit back to the country. And then there are discussions on mutual recognition agreements, visa facilitation, and so on in the context of various trade agreements. So there is a bit of a piecemeal approach across a variety of different types of agreements under bilateral, under health-specific, under trade. Again, what's the impact of COVID on this? One would expect only the demand to rise, as I said, and of course we know that many Indian nurses and doctors are actually out there in other countries addressing this problem. COVID has aggravated the pre-existing shortage and would probably accentuate the pull and push forces. So my focus is really on what should be the possible approaches. So if we look at this growing demand and supply gap, as well as the opportunities that arise in the global market, what really is clear is that one has to look at the workforce as the global public good. And because it's important for all countries concerned. In fact, I would go so far to say that along the lines of the G20 understanding on collaboration and equitable sharing of vaccines and drugs, why can't we also see health workforce as something similar along those lines, some sort of understanding on cooperation? Which means that you do need some sort of resource transfer arrangements, not necessarily in cash, but could be in many other ways, which could be training partnerships, skill development, but the partnership concept has to be ingrained in future agreements regarding health worker migration. And India needs to have a long-term strategic approach so that it is beneficial. You are able to exploit the opportunities that are out there, but you don't undermine your own domestic capacity. So migration management, facilitation of. Now this could happen at various levels. It could happen at the organizational level between institutions. It can happen through domestic policies, and it could also happen through international arrangements, which could be bilateral, regional, and multilateral. And the important thing to recognize is all of this has to be consistent. It has to be coherent. So I would say that the international arrangements, the multilateral codes and conventions that exist have to underpin the domestic policies. They have to be embedded as principles within the domestic policies. So what do I mean by that? If you look at organizational strategies, for instance, twinning arrangements. So hospitals in source and destination countries can develop the links. So there could be staff exchanges, there can be educational support arrangements. But as I said, these cannot be standalone. They have to be underpinned by the domestic strategy. They have to be underpinned by the international principles and guidelines. In domestic policies, certainly restrictions don't work well when the basic incentives remain. So what does the focus have to be? On increasing the supply of quality health workers, through improved training, augmenting the supply through supplementary cadre of health workers, retaining them, and incentivizing return and circular mobility.
Rupa, you have short time left, so another minute, and I think you
sure.
Thank
Sure.
you.
So this will require career upgrading, partnerships, addressing issues of fees and exploitation, human resource practices, and I would say a very robust human resource health cell, which does a lot of the activities that I've outlined there on collection of data, assessing demand-supply gaps, as well as having a master plan for 25-year period. And on bilateral arrangements, the main point I'd like to make is that these bilateral arrangements have to have the concept of shared responsibility between sending and receiving countries. This has not been always the case in the past. So these are some of the important elements the bilateral arrangements have to address: ethical codes of practice, capping active recruitment from selected countries, compensation or resource transfers, skill building, safeguards, institutional cooperation mechanisms, MRA facilitation, provisions on wages and working conditions, making sure that labor market and economic needs tests are done. And then there are a lot of interesting practices from the regional processes. If one looks through CARICOM, Mercosur, ASEAN, EAC, East African Community, there are a lot of good practices there which actually could inform many of the bilateral arrangements countries are getting into. They're not perfect, but I think they can be adapted. And these are the institutional mechanisms that one should look at for best practices. And finally, on just one second on the multilateral. I know that someone's going to talk on the WHO code. I just wanted to mention that there are some governing principles in the WHO code. There's the Global Compact on Safe, Orderly and Regular Migration. Again, there are certain things there which are very important to take note of by the countries, including India, on data, on fair and ethical recruitment, etc. And then there's the transparency, fairness, mutuality of benefits. So I think there is a lot out there that can guide countries in the way they do their bilateral arrangements, very explicitly trying to recognize the negative effects of migration and trying to make sure that there is mutual benefit. So I will end here. Thank you.
Thank you, Rupa. That was really comprehensive, and we move on to Thomas Zapata, the Regional Advisor, Human Resources for Health, WHO, Sierra. Dr. Zapata. We can't see you.
Okay.
We can see your PowerPoint. Yes. We can see your PowerPoint, so you can proceed. Yeah.
Very good. So if you can see the PowerPoint.
We can see you also.
Welcome, Dr. Thomas Zapata. Please carry on.
Okay, good. So thank you very much for the invitation to WHO to be part of this interesting seminar. So the main purpose, here it is, the first slide. So the main purpose, we were requested to present on the study that we conducted in 2017 on migration of nurses and midwives in Kerala. So that would be the first part, and the second part will be on giving some outline on the WHO Global Code of Practice on the international recruitment of health personnel. So, moving to the first part, it was a joint effort between WHO, the government, the state of Kerala, Oxford Policy Management, and funded by the European Union. So, this is the report. It's accessible on the internet, so you can look at it. In terms of production, what we saw in Kerala is that for the past 10 years, there was an increase in the number of training institutions, and mainly 90% of them are private training institutions. So it's very much focused, the growth, it was very much related to migration. Many of those private institutions opened because there was a good market for nurses migrating overseas. When we look at the production capacity, the number of seats, what we see is that there has been a reduction in the number of diploma nurses, GNM, General Nurse Midwife, while there has been an increase in the number of bachelor nurses. So that's the tendency in terms of the number of seats in the country, and again, 91% of the seats are private seats. When we look at the nurse registration in the Nursing Council, it's interesting to see a decline a reduction in the number of registrations by GNMs, diploma nurses, while there has been an increase in the number of bachelor nurses registering with the Kerala Nursing and Midwifery Council. The reason for this is because those nurses going for a bachelor degree, they are more marketable to migrate abroad to the Middle East, to the Gulf countries, and also to the US and UK, as we will see later. So there is a clear tendency on that one. Then if we look at the stock, this is based on NSSO 2012, which you know is a household survey. So basically what you see is that the Indian average is 3.1 nurses midwives per 10,000 population. As I say, this is household survey, this is household data, self-reported, and it's very far, and this is very typical from council data. You know that basically we are overcounting those who have retired, those who are working out of the health labor sector. So anyway, this is household data. But what we see in Kerala is that density was 18.5 per 10,000. So it means that Kerala had 6 times higher density than the Indian national average. So in that sense, this is interesting because Kerala is a good example that they have quite a lot of nurses, and we will see later on if they need more or they don't need more. But it's kind of quite unique because it's the state in India at this point with the highest number according to the NSSO. So that's very different with the situation in UP, the situation in Chhattisgarh, situation in Bihar. So I think being India kind of a subcontinent, we need to be very specific of when we are talking about migration, which state we are talking about. So if we look at Kerala in terms of vacancies in the rural areas, we see that the vacancies are really low. Actually, there are no vacancies. However, if you look at many other states in India, you will find very high vacancy rates in the rural areas. So that's why I was referring that it was a very concrete example, the one of Kerala. And what is going on in the private sector in Kerala? We don't know, as we don't know in most of the states in India. It's kind of a black box that we don't have any data on that, and that's something for sure that we need to improve if we want to have a better understanding of the health labor market in the different states. So now we move to migration, and what we saw is that from 2005 to 2010, there was a significant, a very important decline in the migration in the nurses from Kerala migrating to the UK and to the US. You can see the big drop in those two. And where did they started going? The Gulf countries, as the Secretary mentioned in the introduction. So you see that only 3 countries in the Gulf represents 50% of those migrated nurses from Kerala: Saudi Arabia, Emirates, and Kuwait. And then, as you can see, US only 6.1% and UK to 10.2%. So we have a situation with low vacancy rates, we have pretty high density stock, we have migration going out. But what has been the tendency in the last 5 years when the study was conducted? So we see that the red line is increasing the stock of nurses, but at the same time you see a reduction, a 31% reduction in the number of nurses migrating, especially to the Gulf. So this represents a problem for the state, because you have a situation, you are heading into a situation of oversupply of nurses. You have increasing stock, increasing production, with reducing overseas migration. So it means that more nurses are getting into trouble to get a job. And maybe one answer could be, maybe they are migrating internally within India. Let's look at the graphs. In the previous one, in the overseas, you saw that it was 20,000 nurses working abroad. In this one, you see this green bar here is that only 3,000 nurses from Kerala are working in other states. So it means that the internal market is not as attractive as the external market for Kerala nurses. And when we look at where they are migrating, 86% of them, they are migrating to 3 southern, to Karnataka, Tamil Nadu, and Delhi, which basically they are not those states with shortages. So it means that oversupply of nurses in Kerala is not used to fill those shortages in those states with very high shortages, UP, Bihar, Chhattisgarh, or whatever. You see that those percentages are very low for those states. So then, as a conclusion, as I was saying before, increasing production, increasing stock, reducing migration, overseas migration, with low internal migration, that's a risk for oversupply. So in that sense, the health secretary, we were working with him at the time. He signed a memorandum of understanding with the NHS to try to increase again the migration to the NHS. And we were also looking at what were the causes of this reduction in migration of nurses to the Middle East, to the Gulf countries. Some things we got is that the language for Filipino nurses was the soft skills and the language. The English was better than the Kerala nurses. So those are factors that we need to look at in that sense. And then we need to also look at the working conditions, internal working conditions. In that year we were conducting the study, there was a strike of nurses in Kerala, because basically there are a lot of nurses working in the private sector getting extremely low salaries, because they use working in the private sector as a trampoline to jump into foreign, to get experience, to travel abroad and work abroad. So the private companies take advantage to pay very low salaries. So there is a need of regulation at that sense, and probably exploring future markets. But as I say, this is the example of Kerala, which is the highest density. We need to take probably a completely different approach in other states by conducting health labor market analysis and better understanding what is the situation in terms of supply and demand. So let me now go quickly for the WHO Global Code of Practice. I think most of you are probably familiar with it. So it was approved in the World Health Assembly in 2010 after 6 years of tough negotiation between countries. And the main idea of the purpose is a voluntary code. So it means that it's not compulsory. So then the main idea is that this framework, this instrument, allows for the ethical recruitment of health personnel internationally. And I think the main idea of the code is a win-win-win situation. I mean, when we are talking about global mobility, I think we should be talking about a win situation for the source country in terms that they also benefited in terms of the health system and in terms of making sure that they are not taking out health workers from shortage states or countries. That's one. The second win is a win for the health worker, making sure that there is proper legal umbrella to make sure that they have working rights, and that to make sure that that process happens in a right way. And the third win is a win for the destination country. So that's why we are talking about win-win-win situation.
I have to interrupt because you have another minute.
Yes, very good.
Thank you.
Thank you very much. I will finish in 1 minute. So basically, it's about this win-win-win situation. And when signing the different bilateral agreements, I think we always have to have in mind this. And I think it was very well captured in the whole concept note that you have developed. How you balance the needs from the source country versus the needs in the destination country, and also the health worker. I think that's a component. And the code, as you see, is a safeguard for vulnerable countries. Every 3 years there is a round of reporting on the code. The latest one was in 2018. In our region, 9 out of 11 countries reporting on that. And this year there has been a technical expert advisory group to review the relevance and the effectiveness of the code. And India has been a very active part of it, also Indonesia from our region. So basically they have come out that the code is still very relevant, and it's increasingly relevant, but we need to improve in terms of the effectiveness and how we include the code into the national legislation. That it was also raised by Rupa before in that sense. And then I'm showing again the same slide. I'm not going to get into it, but you see the orange dot, that's India. So basically India is below the 44.5 threshold of doctors, nurses and midwives per 10,000 population. But since the Universal Health Coverage Index is above 50%, that's why India is out of the list of critical shortages, which is a problem when you are trying to sign a bilateral agreement with Germany, for example. Because if you are part of these 43 countries or the 57 before in the 2006 report, according to the law in Germany, they cannot come up sign a bilateral agreement. So I think this is a big move for India to get out of the critical shortage list. And anyway, probably you can see later in the presentation different actions and the proliferation of bilateral agreements. So far is 150 bilateral agreements reported. Key issue again, mutual benefit and win-win situation in that sense. And then there is a equal mobility platform. And just 10 seconds. This is the last slide. I just finished. When signing the bilateral agreements, I think it's really important to engage also Ministry of Health, because Ministry of Health is the one representing the needs in the origin country. So I think it's very important that the Ministry of Health is engaged in the negotiation, not only external affairs or foreign affairs or migration. And then conducting health labor market analysis. We have done one in Chhattisgarh, and that's really important to understand what is the situation. You may have an oversupply of nurses, but a shortage of doctors, or you may have an oversupply in one state, but shortages in another state. And in terms of COVID, there will be an increase in India and a reduction probably in the midterm. And I finish here. Thank you. Sorry for getting a little longer.
Thank you very much. And we leave some of the talk for some questions which will be raised by the participants. Thank you indeed. May I request Dr. P. Srinivasa Rao, the Chief Executive Officer of Apollo Medicine, to speak on the topic, please. Can't hear you. I think you need to check.
I think he's sharing screens. He's trying to show his presentation. Dr. Rao, can you start?
Yes, I've just unmuted. I just wanted to share.
Yeah, we can see your presentation.
Yes, please. So I just wanted to present this slide first and then move on to my thoughts. Okay, so I think most of the speakers have spoken about the shortages. I think Dr. Meera has given a good insight into the shortages, and Rupa has given a great thoughts, and Dr. Thomas has also given his view from WHO. I just want to share that the opportunity areas, if you see, there are about 8 opportunity areas in healthcare where there is a possibility of migration of workers. But today, there are only 2 areas where the migration is happening. One is on the top of the pyramid. If you see the healthcare workforce as a pyramid, on the top you have super specialist doctors who are the DM and MCH qualified doctors in India. Then you have the MDMS, who are the specialist doctors. Then you have the MBBS doctors, who are the general practitioners, and the nurses. These are the 4 areas where there is a lot of migration happening now from India to the foreign countries. If you look at the bottom 3 areas, one is the healthcare management, then the allied health, paramedical, and support services. You see, India today has about 3.5 million support service workers and allied health workers, and the need is actually about 6.5 million. So the reason the allied health and paramedical workforce are unable to migrate is lack of recognition of each other degrees. Just like you have Indian Medical Council of India and Indian Nursing Council, which are being recognized as recognized degrees by WHO. The paramedical board degrees and the healthcare sector skill council degrees, which are being offered for allied health, currently there is no equivalency established between India and other countries. I think there is a need for a regulatory framework to start recognizing these paramedical and allied health education from India. So this is the point that I wanted to make. And the second, moving on to the next slide, I just want to share some experience that we had with UK. So we started a program called Global Learners Program. This is actually a program called Earn, Learn, Return. So the Healthcare Education England under the National Health Services has established a hub in India, in Hyderabad, at our office in Apollo MedSkill. So we had an Health Education England NHS office, And the objective of this office is to provide the opportunities to work in UK for Indian nurses. And the program is actually is called Earn, Learn, Return program. So the nurses get an employment for 3 years in UK, and they will also get an opportunity to learn during that 3 years. Not just a work opportunity, but they also get certified in the area of their interest. And they return to India after 3 years. So the objectives are to gain international work experience. Then they get a certification from one of the NHS affiliated universities. They get an opportunity to earn a higher salary. They have an opportunity to pursue a higher education, and they return to India as a global nursing leader. So one of the advantages that we had is, because we had 78 hospitals spread across India, we could employ these nurses as the first batch of nurses which went 3 years ago. The 5 nurses who went have returned and have joined as nursing superintendents in some of our hospitals now. So because the return opportunities have to be provided, that's a critical thing. So this is the journey of a nurse. So what we did in India, we started an English language training. Generally, for a nurse or a doctor to migrate, there are 2 gateways they have to pass. One is a language gateway, and the second is a clinical licensing exam gateway. So we have an English language practice. We will shortly starting a German language and Japanese language practice at Apollo. So we train these nurses and doctors on IELTS and OET. And then after they clear that exam, they parallelly also learn a clinical licensing exam called CBT. So that's an exam for UK, but we are also training them for the US licensing exams as well. So we also train them for OSCE, which is another clinical exam that the nurse has to clear after they land in UK. We train them on cultural practices and give them insights into living and working in UK. And then once they land in UK, there is a UK induction provided by Health Education England. They actually induct them into the community. There will be mentors, the Indian nurses who are working there, they act as mentors for them for 3 months until they settle down. And then they get integrated into the living and working in the UK. So this was a successful model. So far, the numbers we have sent are low. About 50 nurses migrated to the scheme, but there are about 2,000 nurses who are under training. We have close to 80 emergency specialists, emergency medicine doctors who are undergoing training under this scheme now. And the first batch has successfully got trained, and they've just returned. So this is the experience that I wanted to share from our side. So this is what I have to share. So I know I've really taken a very short time, but I would address more queries during the Q&A session.
That is very interesting and very, very important to know that we have a system where we could train, retrain, and unlearn and learn again. Thank you, Dr. Rao. I appreciate that.
Thank you.
I just wanted to, as chairperson, perhaps take a little bit of imperative and give a little bit of my view from a teacher who's taught for about 40 years, over 40 years, in institutions in Delhi. So I just want to give you my feedback a little bit. When we keep sending our medical students to the private institutions for training, for learning, for admissions, we could consider very clearly strengthening our own medical colleges. I'm not talking about the All India Institute of Medical Sciences. That's a different level that we want, and that's a different lot of institutions. In fact, the All India Institute of Medical Sciences, where I have worked for 6 years, has just 50 undergraduate students. The Postgraduate Institute in Chandigarh has no undergraduate, and they have enormous potential. All these institutions can be strengthened, including the Sanjay Gandhi Postgraduate Institution, including every medical school. The problem has been, as I've seen during my course, is that some of the medical institutions in the country, in the college, have staff, the faculty, who partly does private practice. Now, what do we do about that? Can we stop that? If you try to stop them, I don't think it will be possible at this late stage. However, what we could do is that we could include additional faculty in these, and we have lots of medical colleges in the country which are old, which have a tremendous amount of real estate, which have laboratories which are ready, which may be modernized if we need to. And then these institutions could have a fresh number of faculty who are not permitted practicing, as is done in Delhi. In none of the institutions in Delhi are we allowed any private practice, and we get what is called a non-practicing allowance. This would help us increase our seats within India. Why do we need our medical graduates to go out to learn? We have very good teachers. We could involve some of the retired teachers. We could also include some of the smaller hospitals, including the private hospitals, who are willing to get onto the scheme of teaching undergraduate and training postgraduate medical colleges. We already have systems of the DNB which includes increasing the numbers. So all of this could be considered instead of spending so much money from our students, from the parents who send their students abroad, and then in fact when they come back, they find it difficult to enter back into the stream. So this is only to pass a remark about what I think we could do to increase our own seats, which have increased in the last few years. However, the faculty have not increased. So we need to increase the faculty. The faculty can increase, as one of the speakers said, that people don't want to join the government sector, but we could join, because what happens is there are a lot of vacancies, but the vacancies take a very long time to be filled up. Before somebody is going to retire, we need to fill that position up immediately, in fact 6 months before that. We can give an appointment letter later, because some of the brightest people are very good. And I have to tell you that I have had such a wonderful training in Delhi, where I have been in 3 institutions, Lady Harding, Safdarjung, All India Institute, and I retired from the GTB hospital. Our teachers, but we do not have facilities. We have to have equipment provided in our own teaching institutions, because that's where the core group come from who are going to even occupy the private hospitals. So we have good teachers. We need equipment. We need plenty of equipment, and we need plenty of vacancies to be filled up. And I wanted to re-emphasize Dr. Rao's point about there are several positions. There are the nursing assistants, there are the anesthesiologists, there are the lab technicians. We have virtually very few courses for lab technicians. And laboratory technicians are very, very important in today's day and time to be well trained, to provide the kind of service which we find in the NHS and whatever. The technicians there are highly qualified, and they can almost replace the doctor. So I would like to request now, because I believe Dr. Babu is here from the Indian Council of Medical Research, whether he would like to join in and give some opinion. Dr. Babu of the Indian Council of Medical Research. Mr. Rajnikant. Dr. Babu.
I think, ma'am, we have somebody from the Indian Nursing Council. Dr. Dilip Kumar is there. So, meanwhile, we can take his views and then we proceed.
Certainly. Mr. Rajnikant.
Can we have the representative from the Indian Nursing Council, INC, to share their views?
Yes. Can we come in?
Yes, you can start, but please make your interventions short so that we can take as many questions.
See, the one of the issue which the WHO, can you hear?
Yes, we can hear you.
The WHO made a study that the decrease in admission of the general nursing and increase of the admission of the BSc. That is the one of the definitely. Now we are in the process of making the single entry into nursing as per the National Health Policy of 2017. Now the Government of India has already taken a decision that all the schools of nursing will be upgraded into College of Nursing. The other, that's one way of going. And again, we have already had one MRA with the Singapore Nursing Board, Mutual Recognition Assessment. Ours is the only regulatory body would have the MRA with the Singapore Nursing Board. But the problem is somehow or the other, the MRA could not be materialized by the Singapore health institution. They could not make the advantage of this MRA. So we are now working with the Japan, because Japan is one of the country which is shown the interest. So we are asking the northeastern states, schools of nursing, college of nursing, to start the Japanese language so that we can facilitate Japan. And also now the government of India has shown a clear interest in the recent in the budget speech to encourage our nurses for overseas. So now Indian Nursing Council is working with the different councils overseas so that we can see the gap, what is the gap is available. We have recently also revised the syllabus for the BSc nursing program. We are now focusing on the simulation as one of the method of ASCIIs have been introduced in the examinations, and also we have state-of-the-art National Simulation Center has been established in Delhi in Gurgaon with the and the Indian Nursing Council and the SGT universities and the latter. So it is one of the state-of-the-art center. So now the quality of the education we are improving by training the faculty of the many of the medical education nursing education institutions. So now our area of Indian Nursing Council is working with many of the overseas councils to see the gap. That gap through the English, the other is the language and the clinical skills, which we are going to strengthen in our curriculum, so that our nurses are well sought in overseas. The other problem is why the shortage in India. The optimum nurse-patient ratio, whatever the Indian Nursing Council, which various regulatory bodies prescribes, many of the states are not able to implement the optimum nurse-patient ratio. So, for example, if you advertise for a Safdarjung hospital for 100 staff nurses positions, you will get about 1 lakh applications. So, the reason is the private sector is paying very, very less. Even though Supreme Court has intervened, the minimum salary for the staff nurses has given a guideline. Minimum salary in the private sector for the nurses should be given 20,000, but still way behind the 20,000. Many of the private sectors still they are paying 5,000, 8,000. Only corporate sectors, I think that they are able to give 14 to 15,000. So these are the issues. One is we have to create the patient positions. Positions are not created in the government sector also, and also the private sector is also not creating the position as per the optimum nurse-patient ratio. Then we have a number of the educational institutions are very large number are there. We will be able to prepare our nurses to work in the overseas. Thank you very much.
Ma'am, you are not audible to us. You are not audible.
Right. Thank you, Mr. Deepak. Appreciate your input, and I agree with you. The vacancies need to be filled up as quickly as possible. Wherever that will make a lot of difference to the medical quality available in all institutions. Is Dr. Babu there, or Mr. Rajnikant from Indian Council of Medical Research? Perhaps not.
Can somebody from the Indian Council of Medical Research speak up? Do you want to make any intervention?
I would just like to make one intervention about, Mr. Deepak just talked about the salary for the nurses, which I think I'm totally in agreement with. They work very hard and they have a longest training period also. I want to say a little bit about the doctor's training. I mean, this is particularly to the secretary. Please, if you, the student goes.
Yes, I'm sorry to interrupt. I think Mr. Babu from ICMR is also talking alongside.
Oh, right. So, Mr. Babu can talk first. Mr. Babu, please.
Yeah. Good evening, everybody. I am very much enlightened by all the speakers. the issue of migration of healthcare workers. Particularly in ECMR, in fact, we don't have much data on migration of healthcare workers, though we undertook several studies of general migration. So our concern is, particularly of ICMR, is to have create data on the migration of healthcare workers, because whatever we have till now is very fragmentary, as many of the speakers told. So I think if we group feel that we should have data, a systematic data or national data on migration of healthcare workers, we could have some what you call framework for collecting this data. That is very important. Also, once we have data and we can understand what are the demands from our side and what could be our contribution for the international workforce, then we can what you call, based on this data as well as based on the needs and demands, we can develop some strategies for attraction and retention of the health workforce for the country. Because meeting the local demand, our country's demand, is more important than anything else, what I see.
I think, Mr. Babu, you touched upon data. We have PG Shamrit Lugun if he wants to make his intervention.
Right. Hello.
Yes, sir.
Yes. No, data, whereas data is concerned in e-migrate, what has happened that for the ECR countries, which is 18 in number, and which includes all the Gulf countries, and as it was shown that many are migrating to Gulf, especially Saudi Arabia, Kuwait, and UAE. So the now from 2015, nurses going to ECR countries, now they go through what we call country-specific orders. So we have data for that, but for other areas, we because that is compulsory, we still don't have. But if anybody wants to voluntarily put in data, that's different. So, and then in this COVID situation, of course, we'll see, because health care demand in the Gulf countries is expected to only go up. But how it will be in terms of say salary, working conditions, it is to be seen. So I can say that. Thank you.
Right. Thank you very much. So would you like to open the to the panelists to the questions from the participants?
Yes. Perhaps we can have one round of response from the panelists, and then we take one more round of question and answers.
Right. Okay.
So we'll go in the order, beginning from the first speaker, if they have any interventions to make.
Dr. Meera Sethi.
Thank you. I think I will just pick up two issues. One which Dr. Srinivas Rao said about the program on, what was it, earn, learn, and return. I think that's really, having worked operationally on many such programs, linking up qualified nationals, qualified resources to demand and needs at home. And this is very interesting that you allow them to study. But my concern is about the return element. How do you manage that, and how do you actually then make sure that they come back and are able to deploy their skills? So for me, that's a very interesting element. And I think what our last speaker, who talked about data, I think the whole issue of migration in general suffers a lot from data. But I really appreciate if this fragmented data can be really, we could make some recommendations here, and MEA could look into that, because even a simple inventory, if it is start of your resources, which can be done on the website, it's very easy to do where you are located, what your skills are, etc. So I really like to say that as my interventions on this round. Thank you.
Dr. Sethi, can we ask Rupa to also give her thoughts?
Yeah, so let me pick up actually on two issues. One is the institutions that need to be strengthened within the country to make this sort of management of migration better coordinated, better tracked, and so on. So I would go back to the point I made regarding the human resources for health unit within the Ministry of Health, and the kind of activities that it does, strengthening it or supporting it with a bunch of other institutions, think tanks, whatever it is. But I think the tracking of the flow of workers, getting a better sense of what types of workers are going, because we need to have finer categories. What we are getting is basically just nurses, doctors, midwives. We don't really have for many other categories, like paramedics was mentioned. So there are opportunities in other areas. There are shortages in those within the country as well. So I think a finer segregation of categories is required in the data management system. And I think digitization and tracking, I mean, we really have to think of data platforms. I understand that the HRH in Ministry of Health is doing some of this, and we are reporting a lot of the data. So this is one area I think that needs a lot of improvement, lot of coordination with and analysis, maybe even case studies of countries, trying to understand those better so that we can then get bilateral agreements or coordinate or use best practices much better. That's one part. The other is in terms of looking at the labor markets tests and economic needs tests and that kind of analysis much more closely whenever we get into agreements. I think that is not explicitly always included in many of the agreements, and this is a best practice I think we have to consider. So these were my two main points. I think institutional mechanisms, focusing much more on data and coordination, and looking at existing arrangements and what works very well in those arrangements and what we could adopt, and getting a better sense of occupational categories.
Thank you, Durga. Can we ask Thomas Zapata to also
Yes.
give his views?
Thank you. I think my big point, I think, with COVID at the moment is that this is a great opportunity to advocate for increasing the investment in the health workforce. India spent 1.1% of public health expenditure in health. That's nothing if you compare with any other middle-income country. So I think this is a great window of opportunity now that health workers are really playing a critical role in providing COVID services to strengthen the health system and coming to a new normal. And the new normal has to be better than the old normal. So I think this is a great opportunity for all of us to really push to increase the demand, the working conditions, the salary, reducing the vacancy rates at the country level to balance a little bit this health labor market. So that's my first point. Second, I fully agree on the health labor market analysis, and I raised that issue. We need to better understand what is going on. And in order to do that, we need better data. We've been working with the HRH unit in the Ministry of Health. Now we have the National Health Workforce accounts, but there is still a long way to go to reduce fragmentations, to see people, multi-stakeholder meeting. We organized with the Joint Secretary Medical Education a multi-stakeholder meeting. We need to sit on the table, all the different stakeholders, and work together and aligning processes and interoperability between systems to have a better understanding of the situation. I think I would. Thank you.
Thank you. Thank you, Dr. Congress. Dr. Rao, would you like to comment?
Yes, I want to give very quick 2 or 3 thoughts. The first is, I think we know that there is a demand in India, and also there is a demand across the world for healthcare resources. So the world is clearly divided into the supplier countries and the demand countries, where the demand exists everywhere, but there are predominantly 4 or 5 supply countries for healthcare. And Dr. Meera has mentioned that India is one of the largest suppliers, and in fact the #1 country supplying healthcare resources, followed by Brazil and Philippines and few other countries. So I think we need to increase our throughput. The number of nurses that graduate from India, that can significantly rise. The number of doctors can significantly rise while we address our demand. If you look at the globe, the world, I think India is one of the few countries, I think about 4 or 5 countries, which has a less number of postgraduate seats than the undergraduate seats. That means while there are about 60,000 students are graduating medicine, 60 or 70,000 are graduating medicine, only there are about 30,000 postgraduate seats. Out of that, 13,000 are clinical postgraduate seats. On the contrary, if you take US, UK, across Europe, even in Russia, so why these countries are able to accommodate Indian students there? Because they have excess seats. Why are we not doing that? Possibly, I think that is one area, because we being a strong supplier, I think we need to increase our supply. That is one point. The second is we need to regulate our allied health education. So allied health education is totally unregulated today. There are only 8 states in India out of 29 which has got paramedical boards. The rest of the 21 states, small colleges mushroom and they start giving the lab technician, dialysis technician with a very substandard laboratory facilities. I think there's a need for improving the healthcare education infrastructure at allied health education level. Then this is the second point that I wanted to make, and third point to address Dr. Meera's observation on how do we bring these resources back, the return component, the earn, learn and return, how do we accommodate in Indian facilities? At this moment it is possible for us because we have about 78 hospitals with about 14,000 beds in India. But yes, it's challenging when we supply huge numbers and then we need to return everyone. So we have partnerships with hospitals in Middle East now. So they welcome nurses who have got experience in the in Europe. So that's what we are doing. We have tie-up with American Hospital in Dubai, with Aster Group. So that's our long-term plan. Yes, that's an interesting observation. We cannot bring everyone back to India and pay the salaries and match the salaries that they were getting in UK. Yeah, these are my points. Thank you.
Thank you, Dr. Rao.
I think, ma'am, we have some questions coming in the chat box to assist you. I'll just read them and maybe the speakers can take them up. So one of the questions that we have is, can the rationalization of processes like verification of documents help in increasing the number of migrants? Can a single window system reduce the time and effort in getting verification done? The next is, as the global demand for healthcare workers is going to see a rise due to the pandemic, would it be worthwhile idea to consider regulating the migration of health workers through introduction of some sort of immigration clearance for all countries concerned? And the last bit has been, I think the question on data has already been taken up. So the last bit is skill intervention programs and simple documentations and the role that they can play. So perhaps if we can take 1 or 2 more questions because we are really running short on time. So if anybody has a question, we'll take 2 more questions, ma'am, and then we'll ask any of the panelists concerned if they would like to respond, and then we move towards the close. Yeah.
Would the secretary like to? I think the first 3 or 4 questions could be answered by the Ministry of External Affairs directly, because it really concerns them and none of our technical people.
Maybe, ma'am, we can hear the views of the panelists and then.
The panelists would like to comment on the first 3 questions, which is regarding the immigration and the certification of the making it a little easier for the people who want to migrate.
Right. So can I share my views here?
Yes, please.
Yeah, sure. Actually, because we're working with UK, one of the challenges is the data, which has been extensively. So we have started building a system called AT, Application Tracking System, which is built by NHS UK. So any nurse who wishes to apply to work in UK, now they have to fill their application on ATS. So they are actually procuring all this data, but this ATS access is not there for Indian government. I think we should, today, if we have to ask how many nurses are going from India abroad, I think there is no streamlined mechanism of collection of data. So I think we need to track this application tracking systems, or we need to have our own tracking systems which should have access to all the overseas manpower corporation of each state, so that we can track how many nurses or how many doctors are going from each state. Yes, there is a lacuna there and it needs to be addressed. That's a good question. Yeah.
Okay, I think we have one more speaker who wants to ask a question. Sita, you wanted to make some point?
Yes, thank you so much. Thanks so much, Surbhi. I just wanted to actually, from our earlier work with nurses, I actually just wanted to raise this, that, you know, when migration to the US, for example, stopped or declined a lot, we found that nursing colleges also closed in India. We found that there was no more interest in nursing because it was not seen as something that you could move along aspirationally. So I think we have to keep in mind what people also want. And nursing as a profession in India is not a very aspirational profession in some ways, because of the working conditions and everything else that, of course, a lot of the panelists have said. And so this link with migration is actually quite a critical and interesting link to have for health workers. And as Rupa did point out, as a public good, we really need to see it like that. You know, we are one of the source countries. So we really need to invest in our education and allow people to look at it aspirationally. So that if they want to leave, they can leave. And that still leaves us with having more people joining the health workforce here, because a lot of them will be educated and some will need to stay back. That's just my point.
Okay, so we can perhaps we can have a last round of quick, very short interventions, and then we close.
May I just say one thing as
yes,
a prerogative from the chairperson? You know, we talk mainly about migration, but not about retention. Very little about retention. Why don't people live here? Why don't they want to? I think there are very few doctors who want to even live here for some time. We are an older generation who lived, stayed, worked. Times are different, and times today are very different. We have to provide the medical graduates, forget post-graduation, even the graduates. We have to once an undergraduate leaves the medical college, he's looking for a seat in postgraduate. As somebody said, there are very few seats in post-graduation. That's fair enough. But on the other hand, we have to provide lots of things to a doctor to want to stay here. Our hospitals are very inhospitable for a doctor. They're inhospitable for patients. They're inhospitable for nurses. So we have to first just give soap and water, cleanliness and goodness of health and a feeling in the hospitals in India. I'm talking about the government hospitals. I'm not talking about the private hospitals. Private hospitals cost a lot of money. Government hospitals don't have to cost money. We don't have to put money in buildings. We have to put money in people. And people have to be paid well. A doctor's gestational period, a doctor is nothing till he's about 30 years old. Talk about the civil services, talk about the IIM graduates, talk about anybody else. They start so young. And here there's a 30-year-old who's still looking for a job, and there are jobs, they want them, but the vacancies are never filled. So we have to do something for them. We have to better their salaries, better the working conditions. Most of the hospitals don't have a doctor's duty room. And they don't even have a separate doctor's duty room for a female and a male doctor. I was chairperson of the hospital sexual harassment committee, and that was one of the first things which I was brought was this male and female, and these two were in the same room at night. Now, how can you do this? Now, we wrote letters, but something has to happen on the ground for doctors to want. Not only that, I have a request, which I go further. Why would any young person want to become a doctor in India? The top people don't want to become doctors, but that's sad. So there are people who are at the middle level who would like to be. So we have, and everybody cannot sit for entrance exams. There are lots of people who are very good. So we have to keep that in mind, and not just the entrance examination, which helps us pick up people who will become good doctors, good nurses, good paramedics. There are lots of jobs available on the medical system if we put our minds to it. And that's all I wanted to say. Thank you.
Okay. So very quickly, do any of the panelists have any interventions to make?
Yes, let me.
Very brief, Meera.
Okay, just one quick point. I think somebody raised a question of regulation and immigration. Having worked so many years, I do not believe any regulations in mobility help at all. It is, in fact, making people more informed, providing them the relevant information, and raising awareness of the risks is much more, and I think the government has already started work in pre-departure orientation, and that really needs to be set across the board. Secondly, I have to repeat this again, and I was part of the seminar that you had last time, a few weeks ago, on looking at the labor, the GCC returns. And there are very few countries that have actually come up with very strong linkages of return and development policies. There are literally a few examples, a handful, but it can be done. It is a very labor-intensive process, but it is possible, and I think India would be a great example. And my last point quickly is what Sita mentioned about nursing institutions closing down when overseas market is drying up. I think India must also make more effort to attract more students, especially from African countries, in the health sector. It is already doing that in other sectors, because if you look at the data of Sub-Saharan Africa, there are 11 countries which do not have a single training institution. 24 countries have one training institution, and 168 in Sub-Saharan Africa is the data. So I think India can play a role. Thank you very much.
Okay, so if any other panelists would like to intervene, otherwise we close this.
Yeah, can I make just a quick comment?
Very briefly, Thomas. Yes.
Yes. It's about the ECFMG. You know that in order to get access as a medical doctor to the US market, they are going to pass, it was initially 2013, if the regulation institution in the country is not recognized by the World Federation of Medical Education, they will not be able to access the US market. This deadline has been postponed because of COVID to 2014. But I think this is something really important to bear in mind, because if you're going to start working on accrediting your regulation agency for medical doctors, for medical education, graduates, Indian graduates, doctors, will not be able to access the US market in 2014. So I think this is something also to bear in mind and start anticipating. Over.
Okay, so I think now we'll...
Can I say one thing?
Yes.
Just one quick point, which is on CETA, that one has to prepare the domestic health workforce for the domestic market, not primarily for the international market, because the vagaries of international, immigration policies and restrictions and so on will create problems in the domestic market. So that's one thing. And the second is that we need to pursue the MRAs and some of the bilateral agreements much more proactively. We've got them, but we've really not been very successful. So our professional bodies also need to put in more effort into getting into MRAs.
Thank you, sir.
Okay, so it's only fair that I ask Mr. Rao if you have any point, and then we... Yes, I'll ask our Joint Secretary, Shri Yogeshwar Sangwan, who will be making the vote of to get our...
Thank you, Surabhi. So I thank distinguished panelists for making excellent presentations and making this panel discussion interesting. We discussed the intricacies of migration for another important sector that witnesses the movement of Indian workers in the healthcare sector. The discussion covered a range of topics, from the global trends, concerns about ethical recruitment of healthcare workers, and recruitment challenges. These deliberations hold critical relevance in light of the demand for healthcare workers across the globe. Going forward, how we manage foreign versus domestic demand for healthcare workers and professionals will be important in our battle against the COVID pandemic. As discussed by the panelists, there is a shortfall both globally and within India. The Government of India recognizes the vital importance of this sector, and in this way, we have been facilitating the mobility of healthcare workers both to and from India during the pandemic. India Center for Migration will keep organizing more such discussions every month on issues of relevance in the field of international migration. I once again thank all the experts who joined in this discussion today. and I look forward to your continued engagement with ICM in the future. And as some of the panelists pointed out, as far as migration policy is concerned, the general trend and the general thinking within Government of India is of minimum government, maximum governance. So it will not be, the idea is not to regulate, but to let it flow, have migration and mobility partnership agreements, etc. Thank you very much.
Okay, so thank you everybody. We now close this discussion, and thank you to all of you who joined us today. Thank you so much.
Thank you.
Thanks.
Thank you.
Thank you.
Thank you.